haven't got them. We haven't figured it out. Because I'll tell you what, with the folks who act out, I work primarily right now in DBT, so there is some acting out every once in a while. And even the folks who act out the most, I can be very directive with them, and they will listen if I have the relationship with them. So just because, you know, if I don't have the relationship with them, they're going to blow out of there. But I can tell them to stop, sit down, lower your voice. I can be as directive as I want. And if they trust me or if they believe that I have their best interest, then they'll listen to me. So it doesn't matter how troubled or difficult a patient might seem. If you have that relationship, you can have an effective intervention with them. So paying attention to how they respond to you, instead of just, sometimes we'll just say, well, this is just a difficult person. It might be, and let's see if we've really conceptualized them in a way that's effective. Our own time management, going over in sessions, and enabling. So let's say enabling is not addressing therapy interfering behaviors. That's what we would say enabling is. And I kind of like this. To briefly just talk about enabling, helping is doing something for someone that he or she is not capable of doing themselves, right? They can't do it, so you're going to help them. So sometimes we're going to help patients with getting connected with resources that they just wouldn't know how to get, right? But enabling is doing something for someone that he or she could do for themselves. And so we want to be careful that when we are working with patients that we're not jumping in and solving problems for them that they potentially have the power to solve themselves, because now we're just a caretaker. Okay, so we want to ask ourselves, or we want to think about this, are we avoiding addressing things like them arriving late to session? Because if we are, then we might be enabling that avoidance behavior. Missing sessions, not completing their homework. We just kind of let them, okay, you had a rough night, I understand, next. Okay, we're enabling that behavior. Later missing payments, we're enabling that behavior. And fear of addressing conflict. So we're not talking to them about conflict, and sometimes it's because we might feel angry or agitated with them. So we have to be aware, how I'm feeling towards the patient, maybe enabling them to continue this maladaptive behavior that I'm having a response to, which requires my addressing. So here's some recommendations. Always assess for suicide when risk is evident. That's just always. We always want to do that because we always want to make sure that safety is priority number one over everything else. And be mindful of boundaries with time, right? So we're the role models. So if we arrive late, we're communicating to them that it's okay to arrive late. If we go over session when they're distressed, we're actually reinforcing that when you're in distress, I'm going to give you more time. And we don't want to do that, right? I've been guilty of that. So we want to make sure we're mindful of boundaries with time. Seek consultation for countertransference. Again, if you feel angry or you have a sexual attraction or you're just really, really stuck with a patient, there is no shame in asking for help. I know at the hospital, we consult all the time with each other because it's so important. We need to know, and someone else might think of something I would have never thought of, and that's okay. I'm not meant to know everything. Thank God. We want to pay attention to the outcome of our intervention. So this is what I was talking about earlier, is you don't want to fit the patient to your case conceptualization. You want to fit your conceptualization to the patient. This is a human being, and then readjust as necessary. So let's say I felt like I knew what they needed. I knew in the moment was going to be effective, and it didn't work. Okay, try something different, right? We can be flexible in our approach. That's why we have so many different skills. And then utilize an accurate case conceptualization to understand the function. Again, this is so important. We keep saying it. What is the function of their behavior so we know how to intervene effectively? And recognize those patterns of behaviors. That's super important. What is this pattern that keeps coming up? Because this maladaptive pattern is what's getting in the way of their life and their functioning. And being able to address that in the moment, the immediacy, and addressing the process versus the content that we already talked about. And so if you notice that you're stuck with a patient, these are just some questions to ask yourself. And these are more enabling questions, right? Just things to think about. If the patient's stuck repeatedly, how might I be contributing to this problem? Doesn't mean you're a bad therapist. It just means maybe how am I getting stuck? Am I solving their problems? Am I jumping in to rescue them? Am I allowing them to push me away? Right? I can't tell you how many times, especially in DBT, I have patients come up and they'll say, yeah, When I get pissed, I just cut people off. And I'm like, oh, good. So let's predict you're gonna get pissed at me and you're gonna wanna cut me off, right? How about we talk about that now? Let's create a strategy so that when you get pissed, and sure enough, in treatment, they get pissed, they wanna quit therapy. That is a point of immediacy. Instead of just letting them quit therapy, we wanna be able to work through that issue because that's their problem. Well, one of, right? So we wanna be able to address that. Are they people pleasing me? Sometimes patients are gonna come in on time and they have their homework and they're doing really well and everything looks great. And then they go home and they're falling apart. And then they end up inpatient. You had no idea. Well, because maybe they're just trying to impress you. So really being able to know that behavior and the function of that behavior. And that kind of goes along with, are they idealizing or devaluing me? So am I the good therapist? And if so, what does that mean? Are they fully telling me the full story? Or am I the bad therapist and they're trying to quit on me or criticize me? And how can I help them deal with that anger differently? Okay? So those are the recommendations, and that's it.
Any questions?
Why don't we hold, okay. Thank you. Why don't we hold off on the questions? Dr. Salvatore's going to work with Dr. Wong.
Oh, it's going to be Colin.